Let's begin with this clinical case. It's a woman, 70 years old, that come every year at the clinic for evaluation of this early AMD, just some drusen and some RP changes. We perform OCTA on this patient and we found this lesion, this hyperreflective lesion on OCTA that was vascularized. We observed some flow within the lesion. We decided to ask her to come 10 days later, and this lesion turned to an exudative lesion with some cyst in only 10 days. So this OCTA helped us to reveal what we call a nascent type 3. We'll talk about the early detection of exudative AMD helped by OCTA. Let's first begin with the vascularized drusen. These vascularized drusen were identified mainly at the early beginning by ICG. On ICG, we observed some CNV within the drusen. It looked like a drusen on OCT, but on ICG, we observed CNV, this hypercyanescent lesion, no leakage on FA, only on ICG. This concept really emerged with the occurrence of OCTA. On OCTA, we can identify the flow of the lesion and the limit of the lesion within the drusen. Nadia Waid published that approximately 10% of vascularized drusen were concerned by this entity with the vascularization within a drusen in intermediate AMD population. Here is another example of a patient coming. This was a fellow eye of a patient, some drusen. But on OCTA, we observed two flow here, in yellow. On FA, just an hyperfluorescent without leakage, some RPE changes. This was the left eye of the patient. On ICG, we observe these two minimal hypercyanescent lesions that correspond to some two lesions of CNV, exactly at the same localization, and really correspond to what we observed on OCTA. The second concept is the nascent type 3. This was a 75 women that come for annual visit with some RPE changes, large drusen, confluent drusen, some area of atrophy on the left eye. Multicolor imaging reveals the soft drusen. This was the autofluorescent lesions with the pigment changes. Confluent drusen, line 22 in 16, no change in 17. Line 23 in 16, oh, some change in 17 with a small cyst. Line 24 in 16, yeah, in 17, some change, some exudative features. And it was the same on line 25. So something is happening. We perform OCTA and we observe this small tuft here that is much more obvious on the vertical scan, the B scan. This was the FA of the patient, here. On FA, we didn't observe so much, but on ICG, we observe this little point, this hypercyanescent point that correspond to the type 3 lesion, this anastomosis here, we observed on the OCTA, exactly the same localization. But what about this lesion here? We used to consider this like a pigment detachment, but in some cases, it's not only a pigment detachment, it is vascularized and there are some flow inside. These intraretinal hyperreflective foci correspond in some cases, not all of them, in some cases, to a nascent type 3 with a flow inside. So we have to follow up this lesion and to observe this lesion frequently in order to be sure there is no exudative switch on this lesion, and in this case we have to treat them really promptly. So this was the concept of the nascent type 3. we published some years ago. So the take-home message is to perform OCTA, analyze the B scan, and follow up this patient. And finally, the third concept is the non-exudative and quiescent lesion. We published that at the beginning with the ICG imaging. We observed some hypercyanescent lesion, no leakage on FA, hypercyanescent plaque, and this kind of quiescent didn't didn't move. There is no change with time. There are many other groups that publish about it, and it was observed with ICG, this plaque, but we can guess on the SDOCT lesion there is something here with this small RP elevation. These lesions are really stable in time in most of the patient. No exudative feature, so it is non-exudative CNV, what we call the quiescent CNV. Here is an example of FA, no change, no leakage. We only observe the RP changes and the drusen. On OCTA, look the lesion, we colorize the lesion, and here they are really stable with time, no change. So there is actually 10 years that I'm following this patient, no change, no exudative features. Here, another example, really stable, no change on OCTA. We analyze the fellow eye of patients with CNV, and we observe that in 6% of cases, we observe this kind of quiescent CNV. So what differentiates early detection from a quiescent? If at 6 months we don't observe any exudative feature, we consider it is a quiescent lesion after 6 months of follow-up. Just early detection. If not, we can consider it's a quiescent lesion unless we observe any exudative features with time, so this quiescent is converted to an active CNV lesion. So these three concepts of early lesion were really emerged since the occurrence of OCTA in our practice, allowing early detection and prompt treatment. If you want to learn more about it, so please come to the Macular Art meeting in Paris.